Morning, everyone. Thank you for logging on for our webinar today. I'm going to start with a brief introduction and allow people to trickle in here. My name is Isla Childebrand. I'm Clinical Support Manager at Response Biomedical, and I will be hosting this webinar today. Just a little bit about Response Biomedical. We were founded in 1991, so we've been around in the diagnostic space for quite some time. We're based in Vancouver, Canada, and we design and develop ramp technology. We are 100% ramp 100% of the time, and we're also 100% manufactured in Canada. Because we are a medical device, we have to adhere to certain quality standards, such as ISO 13485 and MDSAP. We have a supply of products that are sold worldwide and a line of FDA cleared tests. Today, we are very lucky to have Dr. Gunsolus with us today. She's a Doctor of Clinical Laboratory Science, and as you can see, has many titles: Pathology Utilization Manager, Director of Specimen Referral at Augusta University, along with being an Adjunct Assistant Professor at Rutgers University. This webinar will be 30 minutes long with a 15-minute Q&A session at the end. For the question section, there is a Q&A box where you're able to type in questions. Please feel free to type in the questions throughout the entire webinar. We will go through them at the very end. And with that, I can stop sharing my screen and pass it over to Dr. Gunsolus. And you can take it away.
Hey. Well, thank y'all for having me. Okay. I am really thrilled to be here today presenting on D-dimer, its appropriate use and interpretation for optimal patient outcomes. Even in my own facility, we have been using Response Biomedical ramp equipment for a number of years now. We absolutely love it. My staff loves it. And so I was very excited when they asked me to come and speak to y'all today. So to disclosures, the session is sponsored by Response Biomedical. Our objectives for today will first explain what the D-dimer assay actually tests for. A lot of clinicians don't really understand what are we actually measuring here. And so I'm going to go through, what is it that we're actually measuring? How do you interpret that D-dimer assay result appropriately? There's a lot of things out there that say, oh, you can do this with that assay, and you can do that. But there's not a lot of data to support that. So what data is out there, and how can you use the D-dimer assay appropriately? And then finally, identify what a point of care D-dimer assay would be ideal for a facility. So what exactly is a D-dimer? So when you look at your platelets, and on here, let me see if I can get my little laser pointer to work. There we go. So if you consider that this is a platelet, platelets have these little things off the end called D subunits on their cell surface. Now, granted, this is a very crude interpretation and diagram of a platelet. But when these two platelets activate and they come together, they bond. Their D subunits bond together. Those bonded platelets then form bonds with a red cell. This red cell bondage with the platelets molecule is fibrinogen. What happens then is that there's a thrombin cleavage, and you get fibrin. Then the fibrinopeptide is removed, and you end up with these linking together into this fibrin polymer. You have the factor 8A cross-linking, and with that, you end up with a cross-linked fibrin. And so you can see here where the platelets from different fibrinogen products, they start cross-linking together. This is what fundamentally forms your clot. So when Plasmin comes by and says, I want to break this clot apart, these little pieces of these linked D subunits end up being your D dimers. And these are the little pieces that we're actually measuring when we're doing a D dimer assay. So how do you actually interpret D dimer results? Well, first, high D dimer results indicate simply that a patient has a higher than normal level of D dimer. So remember, how do we get reference ranges, reference intervals? Reference intervals are that 95% of the population falls between this point and this point. That's all a reference interval is. It doesn't say that if your patient falls in that range, that they're fine. It also doesn't say that if your patient falls outside of their range, that they're not fine. So you have to really consider what that reference interval is looking at. You know, your result, if you have a high result, is just saying that the patient has a higher than normal level of D dimer compared to the rest of the population. Well, if it's higher than normal, it may indicate that there's a blood clotting condition. And I have that bolded and underlined. It may. It doesn't say that there is. It says that it may indicate that there's a blood clotting condition. What a D dimer does not say is that there's a thrombus somewhere. It does not say where that thrombus is located. It does not say that, you know, you've got a condition, because false positive results are very, very common. D dimer is an exclusionary test, not an inclusionary test. We want to exclude diagnoses, not include them. And this is because false positive results are very, very common. So what conditions other than blood clots can cause high D dimer levels? Well, pregnancy. And if you think about in pregnancy, you have a constant turnover. That fetus is growing, the placenta is growing. As the placenta grows, it's forming a clot, and then it's got to break it down to grow. And then it forms a clot and it breaks down to grow. Well, that constant breaking down gives those little D dimer pieces off, and you have high levels of D dimer. Heart disease. It's the same thing. When you're looking at heart disease and you've got that increased plaque buildup in the arteries, those pieces break off. You end up with a clot. Might be a little microclot, and it's not really causing a stroke or a myocardial infarction, but it's a little microclot, and your body then dissolves that clot, releasing D dimer. Recent surgery. You've been cut on. You've had to form clots. And in the healing process, your body is breaking those down, releasing what? D dimers. Trauma, same thing. Infection. As the body is fighting infection, it's clotting off the infection into, you know, pus pockets. So there, when it starts to break down those clots, you get the D-dimers. And then you've got chronic conditions like rheumatoid arthritis. Those, you have these little microclots that can develop within the arthritic joints. And as they try to move, it releases those D-dimers. So as all of these conditions that are actually very common and very commonly seen in our emergency departments can cause high D-dimer levels or higher than normal D-dimer levels. What we've also found in studies is that our D-dimer levels rise as we get older, especially once you get above the age 70, and then even higher than that into 80, 85, and 90. The D-dimer results just get higher and higher and higher. When you look at the reference intervals for almost all of the D-dimer assays that are on the market, they only used patients that were between the ages of 18 and 65 to determine what that range is. So the elderly are not included most often with the determination of your reference interval, and so almost always your elderly flag high. That is just something to keep in mind when you're using this test. So if you've got a test that is high in all of these very common conditions and is high in the elderly, then why use it? Well, D-dimer is a test of rule out. It's an exclusionary test. If you have a normal D-dimer level and that patient is a fairly low risk patient, you can quickly rule out a thrombus condition. If the D-dimer is low or normal, then the patient isn't really high risk. You know, they've got, okay, their leg hurts, but that is the only symptom that they have of a DVT, is that their leg hurts. They don't have any swelling. They don't have any other issues that are potentially a DVT. You can run a D-dimer. It's negative. Okay, it's not a clot. Yay, I don't have to send them to radiology. When you're looking at PE especially, that's a little bit trickier. You've got Wells pretest probability. And this goes into helping determine if your patient has got a low, an intermediate, or a high probability of pulmonary embolism. And so to apply the Wells pretest probability, you look for your clinical signs and symptoms of either a DVT or a PE. You know, are they having that sharp chest pain? You know, is it that kind of, you know, that kind of chest pain where you can't catch your breath really? Do you have no alternative diagnosis? Is PE the only thing on your list? Do they have a heart rate greater than 100 beats per minute? You know, if they're tacky, that certainly plays into a higher probability. Have they been immobilized? You know, have they just been on a long road trip? Have they been on a flight? Perhaps they work perhaps they work in a position where they're at a desk all day long. You know, what is their immobilization? Maybe they've had surgery in the last few weeks. Those go into an increased risk of probability. Have they had a previous DVT or PE? That certainly increased the risk. Do they have hemoptysis? That would increase. And then finally, have they had a malignancy with active treatment I should say treatment instead of treat. They had a malignancy with active treatment in the past 6 months, or they have an active malignancy and they're under palliative care. Either one of those, we do know that there is a strong link between malignancy with chemotherapy or end-stage malignancy and PE. So you look at all of this information and you score the points correspondingly. You add all of those up, and when you're looking at your total score of all of those points, if the score is less than or equal to 2, it's a low probability of a pulmonary embolism. You can run that D-dimer, and if they've got that low score, you can rule out a PE. Intermediate probability, a 2 to a 4. You run that D-dimer, they're on the 2 to 3 side, yeah, you can rule it out. 4, I would consider, what is causing it to be a 4? Is it that there's no alternative diagnosis and that's giving you 3 points? Look and see, well, do you really have no alternative diagnosis? Look at your differential again and see what other things could be potentially causing the patient, and recalculate your probability. If you've got a high probability with greater than 4, at that point, you really need to consider just bypassing the D-dimer. So this is how you would use it in practice. You've got a patient and they are concerned for PE. You do your pretest probability, and your pretest probability shows it's a 3, it's low to intermediate. I'm going to run that D-dimer. If that D-dimer is negative, no PE. I can remove that from the differential and I can focus on other potential diagnoses. If that D-dimer is positive, well, then you need to consider your diagnostic radiology. If your initial pretest probability was high, just bypass the D-dimer. Go straight to the diagnostic radiology, because the D-dimer is not going to give you any true clinical value at that point. Go straight to the diagnostic radiology, and then from there, radiology can determine, yes, a patient has a PE, or no, they don't. So this is a scenario where you can, the appropriate use of using a D-dimer in practice. So obtaining a D-dimer result, it's as easy as sending it to the lab, right? Well, if you're in a large facility like I am currently, they've got D-dimers available, and you can order D-dimers on your patients and get them back relatively quickly. Unfortunately, not everyone is lucky enough to practice and work in a large facility. I have worked in and overseen smaller laboratories and small facilities, especially the last one that I was in was a rural acute care hospital, and it was roughly an hour and a half from the next tertiary care facility. So when you're looking at your smaller facilities, your rural facilities, urgent care centers, freestanding emergency departments, these types of facilities are their labs are less likely to be able to have a D-dimer available rapidly. And so this can be a challenge for physicians that need to really be able to rule out these thrombus conditions very quickly. But what if that D-dimer was available on a platform that was specifically for low volume facilities. So the lab could run it. What if it was point of care? So point of care D-dimer, you can rule out your PEs, you can rule out your DVTs in your lower probability patients. This would be a game changer really for smaller facilities, your urgent care facilities, your freestanding EDs, because it would eliminate your need to call in or even schedule an outside radiology, whether that is a chest CT for your PE or a lower limb ultrasound for your DVT. You know, you don't have to call in radiology where a lot of smaller facilities, if their radiology techs are call in, or if you don't have on-site radiology, you've got to call and schedule it, and it might be days before you can get your patient in. It would improve your ED throughput. Having this available, especially in your smaller facilities, your urgent care facilities, being able to improve your throughput, you would improve your patient satisfaction because the test does not take that long. It takes about 15, 20 minutes to run. And that is a lot faster than having to call in and get them to go in for a radiology exam or schedule a radiology exam somewhere offsite. You can rule out that condition very quickly and much, much cheaper. Running this as point of care is way cheaper than doing the radiology study. Now, if you're in the US like I am, you've got the whole insurance game that you've got to play. And trust me, we hate playing that game. You know, but the D-dimer is much less costly on our patients' bottom line than it is on the radiology would be. If you're in an area that outside of the US that is, say, socialized medicine, it is a lot cheaper on the facility to just run the point of care or even have the lower volume D-dimer available than it is to run the radiology. So overall, it does reduce costs. Now, Response Biomedical has got two platforms that they offer. First is their ramp, and this is this equipment you can run one at a time. It's ideal for your urgent care or your outpatient clinics. And what's nice about this one is that you can actually, it's mobile. You can move it to the patient bedside. It is very nice to be able to do that bedside point of care. They also have the Ramp 200. My facility has a Ramp 200. And this is ideal for your freestanding EDs, your critical access, your small acute care facilities. And you can customize this configuration for either 2, 4, or 6 tests that all can be run at the same time. You can add tests, you can, at any time. So you can be running in this one module right here, and then 2 minutes later, add another one right here, and then the next minute, add another one. And so you can constantly be adding in more patients to get them running. And so both of these platforms are very easy to use. My facility, we have our D-dimer on, because we are a large facility, we have it on our automation line. We use the Ramp 200 for NT-proBNP because that's not available on our automation line. My staff absolutely love the Ramp 200. We've had it for a number of years, and literally the only problem that we've ever had was we had one time where one of these was having issues reading the barcode in the cassette, and Response Biomedical exchanged it out, no problems, and we have been flying great ever since. It has been a fantastic customer service with this company, and we could not be happier. With that, you can run other tests besides D-dimer on this product line. I was just mentioning the NT-proBNP, and so that would be of interest if you're looking at bringing this system into your ED or your urgent care center or your rural acute care, your critical access facilities. There are other assays that can be run on this. It can be run on both the RAMP and the RAMP 200 systems. So there's the NT-proBNP. And NT-proBNP is actually favored now over just regular BNP for screening, because we found that a lot of your morbidly obese patients, your patients with BMIs that are over 40, they don't cleave the NT-pro portion off the BNP, and so you end up with false negatives on a regular BNP test. So when you're looking for your congestive heart failure in your morbidly obese patients, that NT-proBNP is the test to go. And then also, if you're monitoring your patients, if they're on Entresto, you have to use the NT-proBNP, because that's the whole point of Entresto, is to stop that cleavage. You can also run troponin I on either one of these RAMP systems. That is nice if you do not already have access to troponin in your facility. And then quantitative total beta HCG. You have those patients that come in and you're concerned, are they pregnant? Are you concerned they might be having a miscarriage? Are they having, one of these issues? That total beta HCG would certainly be an asset. And a lot of, your critical access urgent care centers, they may have just the regular pregnancy test, but not have a quantitative beta HCG available. And so all three of these are available on the RAMP platform along with the D-dimer assay. So I hope I have given y'all some good information about D-dimer, about how you best utilize it. Remember that there are a lot of things out there saying, oh, you can use your D-dimer and trend this and trend that and everything. And really, there's a lot of the research that's out there doesn't really support that. You'll have one study that says you can use it that way, and then somebody tries to duplicate it and they don't get the same results. So that trending of the D-dimers is not really a good use of it. It is strictly can I exclude a low risk patient from having a DVT or a PE? Or, is this someone that I need to look at and say, you know what, they were kind of intermediate, low to intermediate. They now have a positive D-dimer. I need to look at this and get the CT done or the ultrasound done. And with that, I will take any questions.
Perfect. Thank you so much, Dr. Gunsolus. That was really informative. We do have quite a few questions coming in. Are you ready to go?
Sure.
Okay, perfect. First question, can you speak to the pathology of D-dimer and COVID?
So there are a lot of differing views out there. I think that it is really hard to split out everything when it comes to COVID, because when you're looking at COVID, everything had pretty much gone straight to print and bypassed our peer review process. And what has happened is that we have a lot of research that has been pushed out there that is absolutely horrible research. I'll tell you that myself, I have not been able to come to a definitive conclusion one way or the other when it comes to utilizing D-dimers in COVID. Like I said, there will be one study that says, oh, you can trend it in this, and then another study tries to duplicate what they did, and they don't get the same results. I think a lot of that has to do that these studies are being written and published so fast that they're not really fleshing out who their patient population is, and they're not really reporting very well on either side. You know, what demographic are they truly looking at, and they're, you know, picking and choosing, you know, which patients that they're going to do. I think now that the pandemic is, I don't want to use the SLOW word because that will just jinx us. But now that it's calming down, we can get back to truly peer reviewing a lot of this and really delving into, is this good research, instead of it just coming straight to print and us taking it as gospel before it's actually been vetted.
Mm-hmm. Very good. If the D-dimer test is used to rule out diagnosis when it's high or low, as you said, what's the value of having a quantitative result?
So the quantitative is a much better test than the qualitative. The qualitative test that we used to do, I kid you not, we used to do them. They were on cards, and you put drops and you stir it, and we would stand there and shake it around like this and look for a reaction in the well and say, oh, I think I see stuff, and call it positive. Right. That's what the qualitative tests are. The quantitative tests, all of the quantitative tests are a instrument-based, instrument-read assay, and so you standardize that process. I don't know of any qualitative tests that are out there that are instrument-based. There are all these little things that you either shake, or they've got, I think there's a couple of them out there that are like the lateral flow, which are, that's a whole nother conversation that I'm not, yeah. But manual read on those is just, But when you're looking at your patients, there are some groups out there that are thinking of having different reference intervals for different ages. Mm-hmm. That would require some more research to be done, and more reference intervals to be made, so that you can adjust for those age changes as we increase. And having that quantitative cutoff would the only way that you could do that.
Perfect, thank you. That actually leads me into the next question. Does your facility use any specific reference age ranges for pediatric patients for D-dimer?
So currently we do not. There are several assays that we are looking into expanding our pediatric ranges in. This is an under-researched area. Mm-hmm. And it would be interesting to see what pediatric ranges would be. Mm-hmm.
Okay, perfect. Next question is, how do you interpret the case when you have both a decline in protein S and an increase in D-dimer, suggesting an increase in fibrinolytic activity?
So my first question would be, what medications are they on? Because if you're trending it, more than likely your protein S is dropping because they're on anticoagulants.
Mm.
And your protein S is wrong.
Okay.
I see that a lot. Every facility I have ever worked in, a lot of clinicians do not realize that when the lab is measuring a protein C or a protein S, they're actually measuring a clot, the formation of a clot. So if you're giving your patient anything to inhibit the formation of a clot, your patient's going to have incorrect results. And I've identified numerous patients that have been incorrectly diagnosed with either protein C or protein S deficiency because the test was simply done while the patient was on anticoagulants. So that would be my first thing to look at.
Excellent. Thank you. How critical is a fast diagnosis when you're treating a DVT or PE? Would having D-dimer at the point of care greatly improve patient outcomes?
Yes, it would. I have seen patients that have gone to some of our outside affiliated rural facilities that do not have D-dimer, but trying to get them to get D-dimer, but they haven't. And they actually transfer their patient to us because, oh, we think they now have a PE when it started out as a DVT and that clot has now thrown and they've now got a PE. I've seen patients that, you know, they should have been worked up in an urgent care center for DVT. They went in for leg pain and they were just treated with a steroid, and next thing you know, they're in our ED having a stroke because they've thrown that clot. You know, these are issues that we see. It's catching that patient that appears to be a low risk, but you run that D-dimer and you go, oh, you know what? I should probably investigate this just a little bit more. Because it goes, it should ring off an alarm bell that, you know what? I need to do just a little bit more investigation in this so that this patient doesn't end up having a stroke, having an MI because I missed a DVT, or, you know, this patient progressed and now has bilateral PEs because I missed the initial signs of the first. So yes, it does affect.
Perfect. Thank you. This is a long one.
Okay.
Anti-D-dimer antibodies have been shown to react with fragrant D-dimer, but also some detect dimeric D domains within larger fibrin compounds, including cross-linked fibrin complexes generated in early coagulation. Is there a reason to prefer a test method that is specific to fragments only versus a test that detects also the larger complexes?
That is a very good question, and I would have to look into that further. Honestly, I've never been asked that question before. So,
wow, what an honor. I know you've done thousands of these.
I would have to look into that. I'm writing that one down.
All right. I can send it to you too. We can provide
yes, please. Because that's piqued my curiosity. I'm gonna have to look into that.
Excellent. And so I think we have one more question. Do you think that speed of results or simplicity of operation is more important for a test like D-dimer?
Well, number one, quality results. That's number one. I would say that simplicity or speed, simplicity or speed. I would have to go with speed and then simplicity.
Mm-hmm.
Only because, I mean, if you end up with a test that takes 2 to 3 hours to run, it's not going to be simple at all.
Right.
You're going to have to, someone's going to have to remember to go back and do something with it, which is nearly impossible in a point of care setting. So I would say speed, because the faster that it runs, yeah, I would still go with speed. I would still go with speed. But I will tell you that from my staff, they say that the ramp system is super easy. So.
Oh, that's so lovely to hear. Thank you. And thank you so much for answering all of those questions and for your presentation. That was super informative. And yeah, thank you for everyone who attended as well.
Sure. Thank you.
All right. Thank you. Have a great day, everybody. Bye.